Hello and welcome everyone. Myself Dr. Himanshu Dave, and I am from my channel MCQs Next, and we are starting this medicine lecture series, which is Harrison based, and this is useful for new PG, FMG, MBBS students as well as MD General Medicine students. So today is the first lecture of this series, and we are trying to uh, compile the syllabus of general medicine, short notes basis important topics. So around 100 topics we will deal with, and one class for each topic. So we are starting with first important unit of neurology, and today's topic is stroke. We will read about ischemic as well as hemorrhagic stroke. So these are short pointed notes, crisp notes, and which is easy to revise, especially for students who are preparing for MCQ exams, and also small but important concepts for MD students or MBBS students. Okay, so now we will move and we will start this lecture. So first of all, we will look for some definitions. So first is stroke. What is stroke? It is rapidly developing signs of focal or global cerebral dysfunction lasting more than 24 hours. So important words are rapidly developing signs of focal or global cerebral dysfunction lasting more than 24 hours, so leading to death with vascular cause. So vascular cause should be there. What are the important points? Vascular cause should be there. Duration should be more than 24 hours. Focal neurological deficits is usually present. So this is definition of a stroke. Now next is TIA. What is TIA? Neurological deficit which lasts less than 24 hours, but now it is defined by no infarction on imaging. That is, initially it was time-based definition. Initially it was time-based definition. That is, if the deficit is less than 24 hours, then it is TIA. But now it is tissue-based definition. Tissue-based means that on MRI or imaging, there should be no parenchymal, no tissue damage. So no infarction on imaging, then it is TIA. So duration is not of much importance now. The important part is infarction. So time-based versus tissue-based definition. It was old definition was time-based, new definition is tissue-based. So stroke is tissue injury is present and TIA is no tissue injury. So these were few definitions. Now if we'll go through the types of stroke. What are the two major types of stroke? First is ischemic stroke and second is hemorrhagic stroke. Ischemic stroke is the most common one. It comprises around 85% of stroke patients, and hemorrhagic stroke is less common, and it's about 15% of the total patients. This hemorrhagic stroke is again subdivided into subarachnoid hemorrhage and intracerebral hemorrhage, that is parenchymal bleed. So these are the two types of hemorrhagic stroke, and one other type is CVST, cerebral venous sinus thrombosis, is also there when venous infarcts are seen. So this is about types of stroke. Now first we will go through the important one and the common one, ischemic stroke. Now what is the pathophysiology of ischemic stroke? We will read about 2 points. First is core infarct and second is ischemic penumbra. So what is the infarct core? The irreversibly damaged tissue is the infarct core. And what is ischemic penumbra? This is hypoperfused. Each word is important. This is hypoperfused but salvageable tissue. So this ischemic penumbra is target of reperfusion therapy. Now suppose, let's make a simple diagram. This is brain, two hemispheres, and now this is the part which is damaged. So this is core infarct, and this is the area, surrounding area. Let's draw with some other color. So this surrounding area is ischemic penumbra. So this is the tissue which is hypoperfused. That perfusion is not proper, but infarct has not developed yet. So this is what? This is core, and this is the yellow one portion is penumbra. Okay, so this penumbra is salvageable tissue, and this is the target of any reperfusion therapy, because the area, the core infarct area where the irreversible damage has already occurred, no any intervention or any drug will reverse this tissue damage, but ischemic penumbra can be salvageable. It's salvageable and can be saved with the reperfusion therapy. So time is brain. This is very important saying in terms of stroke, because we need to save this ischemic penumbra. So as soon as the symptoms of stroke develop, visit hospital, nearest facility where neurological facility is available, neurology department is there, and we should get treatment started as soon as possible. So just about this fast, how to recognize these symptoms of a stroke. Fast, F stands for face, that is facial deviation. A for arm or limbs. Okay, A for arm, but it stands for limbs. So upper limb and lower limb weakness, mostly unilateral. So this is FA, and S for speech, that is slurring of speech, okay, or slurred voice or dysarthria or aphasia. So any speech abnormality. And then time, T stands for time, timely intervention is required. Okay, now recently fast has been extended to B fast. B for balance issues, that is if gait ataxia or inability to maintain balance, and E for diplopia or decreased vision or blurring of vision. So this is the mnemonic everyone should remember, and even general public should remember, and they should know if these following symptoms are there, then they should reach the nearest facility for treatment. Now important part is classification of ischemic stroke, how it is classified, and this TOES classification a very important one clinically as well as for MCQ purpose or exam purpose. So TOES classification is the important classification of ischemic stroke. There are how many types? 5 varieties of ischemic stroke has been classified. First is large artery atherosclerosis. So large arteries, internal carotid or the large vessels are occluded, and this occurs, the pathophysiology or mechanism is atherosclerosis. The second one is TOES2, is cardioembolic due to the cardiac causes like any valvular heart disease, okay, valvular heart disease or atrium dilatation, so or atrial fibrillation. If the embolus is going from heart, then it is termed as cardioembolic. So cardioembolic is the second one for TOES classification. The third variety is small vessel disease, small lacunar infarcts, and small vessel disease, ischemic disease. So third is small vessel disease. Fourth is stroke of other determined etiology. Okay, so if any other determined etiology like PFO or other rare causes are there, so that comes under stroke of other determined etiology, that is TOES3. And TOES5 is stroke of undetermined etiology. After thorough evaluation, if no cause has been established, then this comes under category 5 of TOES classification, stroke of undetermined etiology. So this is important even for MCQs. Now common risk factors of stroke, if we go through, then the most important risk factor is hypertension. Second one is diabetes mellitus. Third is smoking, atrial fibrillation, dyslipidemia, carotid stenosis. So these are some of the important risk factors for stroke, ischemic stroke. Now clinical features are localization based. Mostly ischemic stroke has been classified into two varieties. First is anterior circulation stroke and the other is posterior circulation. This is on the basis of the blood supply to brain. And in anterior circulation, mostly middle cerebral artery and anterior cerebral artery involvement. So if middle cerebral artery, that is MCA involvement, is very common. ACA involvement is quite less common. So in middle cerebral artery, what are the features? Contralateral face and arm, and more than leg weakness. So this can be asked in MCQ, that contralateral face and arm weak, but more than the weakness in contralateral face and arm is more than the leg. Aphasia, dominant hemisphere, mostly if left hemisphere is involved, then it leads to aphasia. Neglect if non-dominant, that is right hemisphere is involved, then it leads to neglect. And homonymous hemianopia. So these are the 4 important and common features seen in middle cerebral artery infarction, MCA territory infarction. Now about ACA, contralateral leg weakness. Arm and face weakness is not there, only leg weakness is usually seen, abulia is seen, and urinary incontinence can be seen. Mostly frontal lobe is involved or uh, this frontal area is involved. Okay, so this is about AC territory. And now about posterior circulation, it is again divided into two: PCA infarct and brainstem stroke. So in PCA infarcts, what happens? Visual field defects is there and memory loss can be there. And in brainstem stroke, usually cranial palsy is seen and contralateral weakness is seen, that is crossed findings. Cranial nerves of ipsilateral side and contralateral side weakness is seen, like various midbrain and medullary syndromes. So this is common finding in brainstem strokes. Now the other uh, point is about lacunar syndromes. Lacunar syndromes means small size of infarct, small size of tissue damage. It is caused by lipohyalinosis. The cause of lacunar infarct is lipohyalinosis. Now, syndromes and their features: if the pure motor stroke is there, then mostly internal capsule is involved. If pure sensory stroke can be seen in thalamus infarct. Ataxic hemiparesis can be seen in pons involvement, and dysarthria with clumsy hand is seen in pons involvement. So these are the important lacunar syndromes, which is classified on the basis of the area of involvement. Investigations: how to approach in a patient with stroke, ischemic stroke, especially immediate investigations and later. So immediate investigation is non-contrastivity of the brain. NCCT brain is very important. It rules out hemorrhage. Okay, during very early stage, early few hours of infarction, it is not visible. So early infarcts are not visible on CT, but it rules out hemorrhage, so we can go for treatment of ischemic stroke. Blood glucose to be seen and ECG should be done to rule out any cardiac issue or atrial fibrillation. And after stabilization or after some time, the MRI, diffusion weighted MRI, is most sensitive investigation for infarct. So which is the most sensitive investigation for infarct? This can be an MCQ question. So diffusion weight imaging is the most sensitive investigation to detect infarcts, and carotid Doppler should be done to rule out any thrombus or stenosis in large vessels, and echocardiography should be done to rule out cardioembolic causes of stroke. What to be seen in echocardiography? Valvular walls should be seen, atrium, ventricles dilatation, any thrombus, LV thrombus, or if the patient is in atrial fibrillation, it can also be detected by echo. PFO can be detected in echo, which is a rare cause of ischemic stroke, and bubble study is done, and which you can bubble study to rule out PFO. So these are the investigations commonly which is to be done in case of ischemic stroke. Now what is the acute management? Acute management first is thrombolysis. Now what thrombolytic agent is used? IV alteplase. Dose, remember each and every point. Dose is 0.9 mg per kg, maximum dose is 90 mg. And what is the time window? If the patient comes to you in less than 4.5 hours of the symptom onset. What are the symptoms? We have already discussed in previous slide. In that mnemonic we can remember: be fast, that is balance issues, vision loss, facial deviation, arm or leg weakness, slur in speech, and the time duration is less than 4.5 hours. So we can thrombolyze the patient with IV alteplase. What are the contraindications? BP should be less than 185 by 110 mm of Hg. If any recent surgery or active bleeding is there, then thrombolysis should not be done. The other option is mechanical thrombectomy. It is a newly developed procedure, and it is done in large vessel occlusions, that is we commonly say LVOs. So large vessel occlusion is there, and time window is up to 24 hours in selected cases. And how to decide whether mechanical thrombectomy is to be done or not? First, to rule out whether any large vessel is occluded, that is ICA or first segment of middle cerebral artery. And the other thing is diffusion perfusion mismatch is there. Diffusion perfusion mismatch. Okay, so what is to be seen in this diffusion perfusion mismatch or perfusion imaging? We can say Another thing is perfusion imaging. We see the perfusion of tissues, and here what we have read in the previous slides, that is infarct core versus penumbra. This is to be distinguished, and if penumbra is there, if the salvageable tissue is there, then up to 24 hours we can do mechanical thrombectomy. Okay, so this is important and recent advances point. Now, antithrombotic therapy. What is the common antithrombotic therapy? Aspirin should be started. Dual antiplatelet should be done for short term. How many days? Minimum 21 days to 90 days as per different trials. Dual antiplatelet therapy in case of minor stroke, that is low NIHSS score and small infarcts, we should give dual antiplatelet therapy for 21 to 90 days. Usually we give 90 days, that is 3 months. Anticoagulation should be given for atrial fibrillation after risk assessment. How to diagnose atrial fibrillation? If continuous AF is there, then it can be seen in ECG. Otherwise, important point is that Holter monitoring should be done. Okay, so usually in practical scenario in our country we do Holter monitoring for 24 hours, but ideally Holter monitoring should be done for 28 days, that is a month. Holter monitoring should be done to rule out any paroxysmal atrial fibrillation. Okay, so this is about therapy. Now, complications. What are the common complications of ischemic stroke? Cerebral edema and develop hemorrhagic transformation, aspiration pneumonia, and DVT. So DVT prophylaxis is also to be given if the power is very low. Now let's move to hemorrhagic stroke, the other variety of stroke which is less common. So hemorrhagic stroke. Now first we will look intracerebral hemorrhage. What are the common causes of intracerebral hemorrhage? Hypertension is the very important cause and very common cause. So most common cause is hypertension, and the location is basal ganglia and thalamus. Cerebral amyloid angiopathy, if we see lobar hemorrhages. Anticoagulant, if the patient is on anticoagulant, then anywhere hemorrhage can be there. And any arteriovenous malformation, if the patient is young, then we should rule out AVM. So these are the common causes of ICH. Now what are the clinical features of ICH? Sudden onset headache, vomiting, rapid worsening condition, and focal neurological deficits. So if the patient presents with sudden headache, vomiting, and rapidly worsening consciousness and focal neurological deficit, we should rule out intracerebral hemorrhage. Okay. Now what investigation should be done? CT brain to rule out hyperdense lesions, and MRI to rule out any underlying cause like cerebral amyloid angiopathy or any aneurysm. So CT brain is the most important investigation for intracerebral hemorrhage. Now what is the management? Simple, BP control, target systolic blood pressure should be 140, stop any anticoagulants, treat raised ICP. How to treat raised ICP? With mannitol if creatinine is normal, renal functions are normal, or if renal functions are deranged, then 3% saline can also be used. And neurosurgical consultation should be taken in selected cases, because if there is raised intracranial pressure, like this is brain to divided into two hemispheres, these are ventricles, but if in some case there is this is midline shift, the brain is getting shifted towards one side because of large bleed or hematoma, so we have to do craniectomy on this side to release this pressure and to decrease this midline shift. So neurosurgical treatment should be done. Now the other important type of hemorrhage is subarachnoid hemorrhage. This is very important even for exams. So the most common cause is Barry aneurysm. And what is the classic? These are all exam points. Thunderclap headache is seen. What is thunderclap headache? Worst headache of life. These all are MCQ points. Most common cause Barry aneurysm. Clinical presentation, most common thunderclap headache. The patient says this was a worst headache of his or her life. What is thunderclap headache? It reaches. Now thunderclap means reaches to peak intensity from onset to peak in less than 1 minute. So this is like thunderclap, like a thunderstorm. So बिजली गिरने जैसा जो बोलते हैं, या उस तरीके से जो हेडेक रहता है, it reaches from onset to peak in less than a minute duration. इतना सीवियर हेडेक पेशेंट कंप्लेन करेगा कि ऐसा आज तक कभी नहीं हुआ. दिस इज द फर्स्ट एपिसोड ऑफ हिज लाइफ. This is the worst episode of his life. So this is thunderclap headache. Now what are the complications of SAH? This is important. Rebleeding, that if aneurysmal rupture was there, so it can rebleed. Vasospasm, very important complication from day 4 to second week of event. Hydrocephalus, ventricular enlargement can be there in hyponatremia due to SIADH or cerebral cell roasting syndrome. So these are important complications. Now very important point, how to prevent this vasospasm, which is the drug of choice. Nimodipine is to be given. So dose of nimodipine is usually we give as 60 mg tablets every 4th hourly. So nimodipine is the drug of choice to reduce vasospasm. Now a differentiating table between ischemic and hemorrhagic stroke. How to differentiate between these two varieties? Onset ischemic is sudden, hemorrhagic is sudden plus headache is there, and hemorrhagic is, as compared to ischemic, it is more sudden in onset. Vomiting is rare in ischemic and it is common in hemorrhagic stroke. CT brain is normal in early stages, it shows hyperdensity in early stages. Treatment is thrombolysis, or we have seen mechanical thrombectomy in few cases, and here BP control or raised ICP should be maintained. Now secondary prevention of a stroke, as ischemic stroke, antiplatelets. Common antiplatelets are aspirin and clopidogrel. Most common we use in stroke is aspirin. Other choice is clopidogrel or ticagrelor is also used. Statins, commonly atorvastatin or rosuvastatin, can be used. BP control. BP should not be lowered in case of ischemic stroke. It should not be lowered too drastically because it increases the penumbra. That is, it reduces the blood supply, because in case of stenosis, if already stenosis is there, then a good blood pressure is needed to maintain the circulation, and lifestyle modification is the most important secondary prevention. Now few important one-liners for NEET PG or FMG students, which is the most common cause of stroke. Ischemic, as we have seen 85% cases. Most common cause of ICH is hypertension, basal ganglia, putamen. These are the sites, thalamus. And drug to prevent SH vasospasm is nimodipine, 60 mg 4th hourly. Gold standard initial imaging in stroke is non-contrast CT, and later on what we do MRI, diffusion weight imaging for to detect infarcts, and penumbra is the salvageable tissue. So this was a short lecture on stroke, a summary sort of for stroke, and it is useful for students who are preparing for exams. Few MCQs and one-liners are there. And thank you everyone for your patient listening, and you can subscribe our channel Shishu Care on YouTube for more such videos.